So here we can see a occlusal pit and fissure cavity. It's quite a woofer, it's quite large, quite obvious, but on the occlusal surface of the tooth we would probably have quite a large outline form, and we would need to consider very carefully a dental material with high compressive strength. We'd want to design the cavity itself so that it had retentive and resistant form features built into it. Here we can see this is a child patient of mine, and you can see that they have 6-year-old molars, but they still have the deciduous anterior lower teeth, so they're probably about 6 years old. This child's lost a tooth due to caries, and you can see cavitations occurring here both on the occlusal surface and interdentally between the two primary molars. Now here we'd have to think very carefully about what restorative material we're going to use, and in this particular case, because this is a mixed dentition, one of the other things we need to think about is how long this particular tooth is going to be in the mouth. Alright, so that would help us to determine which material we would choose, and of course we would need to know about the durability and the lifespan of different dental materials. Okay, so if this child was much older, if they were 10 for example, we may choose to place a simple restoration here using a glass ionomer cement. But they are 6, so this tooth actually has to stay here for how long? Another 6 years potentially. So we may think of a dental material with greater longevity. In this case, it would probably be a stainless steel crown. Okay, but that's a different story. Here we can see multiple carious lesions, but they are all of the white spot or incipient or non-cavitated type at the moment. But if you just imagine, if we left the plaque here for long enough, we could end up with cavities looking like this, in which case we'd need to think very carefully about the dental material, because you can see here in this picture the patient is in maximum interdigitation, and you can see that this spot here actually is not under any occlusal pressure. So our cavity design, the amount of tooth structure that we remove could be very, very minimal, right? Just restricted to the necrotic tissue itself. And then we could place something like a GIC, for example, because it's under no significant stress, so it doesn't need that compressive strength. We could place a resin composite, but of course it would depend on how well we can isolate the cavity from fluids, because they're very moisture sensitive, right? So if we can get good isolation here to stop the fluids from the gingival crevice from seeping out onto the operative site, then we may choose a resin composite. Here I've included, just for completeness, an example of a class 6 or cuspal tip cavity. You can see here the cavity is occurring on, what's this? This is the lower 6, so there's the mesiobuccal, the midbuccal or true buccal, and the distobuccal cusp. So on the tip of the midbuccal or true buccal cusp, you can see that there is a cavity here. That is unusual because we don't usually see developmental grooves, pits or fissures in these areas. It's probably some sort of developmental defect in this area that's then collected plaque, which has then become carious. Unusual, but you may see this. And as I say, I've included it for completeness here. So, what determines our cavity design? Well, the basics are the disease, how much of the tooth has been destroyed. Right? Is it a very little bit, or is it a big woofer like this one here? Okay, so that will help us to make decisions about what the final cavity design is going to look like. We also, remember, need to think about the dental materials. So what are we going to use to restore the tooth? Is it an adhesive material? Here we've lost one of the cusps of the teeth. So, you know, an adhesive material might be indicated, but it's going to be under significant occlusal pressure. So we need to think very carefully about that. And the dental tissues in the area also will help us to make a decision. Is there dentine involved and enamel, or is it just enamel, or is it large areas of dentine with no enamel? In this area here, you can see we're getting very close to the cementum and dentine of the root. So if we had no enamel left, let's just say the cavity went all the way down to here, then we wouldn't have an enamel margin here to bond a material like resin composite to. So we may be forced into using something like a GIC build-up here, and then a resin composite. This is the so-called lamination technique there to make up for the fact that we don't have an enamel margin here to bond a resin composite to effectively. So you can see that triad, that golden triangle of all those different elements that we need to consider is really important, particularly when we're faced with something like this. Now, the important principles here, I don't know what this thing here is, but it's pretty annoying. Anyway, just ignore that. There are some important principles, and I've put them in very small text so that you focus in on them, right? That's how psychologically it works. You really concentrate on these things now. The principles are principles, right? So they're guiding ideas that we will apply generally across all cavities. So they're principles that apply to cavity design, but the way we apply those principles will be determined by those previous characteristics. All right? So they're all about the form that our cavity will take, and they are in alphabetical order. Actually, they're not alphabetical order. They're in no order. Access form, convenience, retention, resistance, and outline. And the names are very descriptive, so you can probably start to understand what these things mean even before I go on to the next slide. But I will go on to the next slide anyway, if the board lets me. Okay, so the first one is access, and as the name suggests, it's about being able to access the necrotic tooth tissue. Now, if it's a great big woofing cavity where the enamel's collapsed in and you can see the dentine, the disease has created the access for you. But if it's like that one on the radiograph where you cannot not actually see it clinically because it's interproximal, then your access is much more difficult, right? And then you may have to create access artificially by cutting through sound dental tissues to get there. But you need access to be able to see the necrotic dentine, and you need access to be able to get the instruments in to remove it effectively. So access is very important. If you don't have good access to the lesion, you're not going to be able to effectively remove the necrotic tooth tissue. And one of the mistakes people make with minimally invasive dentistry is they think that it's minimally invasive dentistry means really, really super tiny, uber tiny fillings or cavities, where it actually doesn't, right? It means minimal destruction of tissue, but we still need access into it to be able to restore it appropriately. So keep that in mind. So, talking about access, we have two different cases here. Here is a lesion on the distal surface of a tooth. Now, our access, if there was no tooth next door to it, our access would be relatively simple. We just access from the side into the cavity. We'd remove the necrotic dentine, and then we would eliminate any unsupported enamel. So our cavity design would look something like that. We would have no occlusal pressure from this side onto the tooth, so our design could be fairly minimal, fairly rounded, and we might choose to use a material that doesn't have high compressive strength but very good adhesive qualities, and a glass ionomer cement, for example. The other thing about this type of approach is that we preserve this important structural area here, which is the marginal ridge. And the marginal ridge comes under a lot of pressure when we bite our teeth together. So if we can preserve that, then we are preserving more strength in the tooth. However, if there was a tooth next door, we would not be able to access the cavity directly this way. So what we would have to do is to cut through the marginal ridge, eliminate the necrotic dentine, and any unsupported enamel. And so we would end up with an outline that looks something like this. We may cut into the tooth a little more to give us some sort of retention, so we may end up with a step like that. So you can see that the access is actually creating a larger cavity design than is ideal. But what can you do? You have to get to the caries. In this case, we've got an occlusal cavitation, so there's a cavity here, significant necrotic dentine. We want to eliminate this necrotic dentine, so we need to be able to get to it. So we would cut through in this direction with a burr, a high-speed handpiece, until we removed the overlying enamel. We could actually see into the cavity. We would probably extend the enamel removal this way so that we eliminate unsupported dentine. Okay, and so our final cavity design may look something like that. So our access here is more direct and results in less removal of sound dental tissue. The outline form, and apologies for the slide, it's not particularly clear, but what the point I'm trying to make here is that the outline is the outline or the border where the margins of the restoration will be. And according to this slide, placing the preparation margins, so the margins of the cavity, in a position where they are optimally placed to eliminate unsupported enamel, but trying to preserve as much tooth tissue, particularly cusps and marginal ridges, is our outline form. And what this is actually saying is that you should think, before you pick up the handpiece and start cutting, you should be very clear about what your final outline form is going to look like. Let's have a look at an example of that. Okay, so here we've got the occlusal surface of a molar, and this area here is definitely cavitated. Let's assume that all of this fissure pattern here is cavitated. So what we would want to do is to prepare a cavity which removes unsupported enamel, allows us to access the necrotic dentine, and so we would end up probably with an outline form, that looks something like this. Now, what you'll notice about this outline form is that we have carefully avoided the cusps and the marginal ridges of the tooth. And the reason we do that, if we possibly can, is because the cusps and the marginal ridges, and in upper molars the oblique or transverse ridge, are strength points in teeth, and once we start cutting into those, we severely weaken the tooth. Now, if the caries extended underneath this so that the dentine was destroyed underneath the enamel here, then of course we would be forced to open up to remove unsupported enamel. So our final outline form may look something like this. Now you can see the danger here is we've started to cut into the cuspal incline of the teeth, okay, which is going to weaken the tooth, okay. But we need to gain access to the caries and we need to eliminate unsupported enamel. So in this case, we think very carefully about our material. We need to place a material in there that's going to be very resistant to the occlusal forces, quite strong, okay, so quite significant compressive strength, an amalgam perhaps. In this area here, our outline form, as I said before, would look something like this if we could come from this side. We usually can't. So our outline form, well, that's a little bit excessive, isn't it? Our outline form will probably look in cross-section like that. Okay, so that's what we mean by the outline form, where the outline of the margins. And in the simulation activities, you may actually be asked to draw, before you start cutting into a tooth, what your outline form is going to look like. Okay, so remember that. What is the shape from the occlusal or in cross-section on the tooth going to look at? What are the outline or the borders of your cavity? Retention and resistance are two related features or principles, so we'll talk about them sort of together. Retention, though, means avoiding displacement of a restoration in an occlusal direction, so up out of the cavity, straight up out of the cavity. Now, when we used amalgam restorations in the past, because it's not adhesive, we were actually relying on mechanical locking into the tooth surface. So if we consider this light blue area to be the amalgam, what we had to do in order to retain the restoration in the tooth, which is this darker area here, is we actually had to cut what we call mechanical locks with quite sharp angles, okay, so that if we bit on a minty and it stuck to the restoration here, and we opened our mouth, we didn't lose the restoration in this occlusal direction. So that's the retention form. Now, even with adhesive materials, which I'll show you in a moment, we need a certain degree of retention form built into our cavity design, but not as much as we did when we were using amalgam. And resistance is cavity form or shape of a cavity that adequately resists the occlusal forces. And in order to achieve this, we look at the cavity floor and we look at its relationship with the direction of the occlusal loading. Okay, so what this means, actually let's go on to the next picture and I'll show you what it means, because it's a little difficult to understand just using words. Okay, so if we wanted to create the ideal cavity here, we're removing necrotic tissue, we're removing unsupported enamel, we would end up with this type of form. Okay, so what this will do is we've got walls of the cavity, we've got walls of the cavity which are sort of at right angles, if we had straight lines, to the floor of the cavity. Okay, so we've got a box form. So if you think of this room, which is relatively small, we've got a floor, which is here, and we've got walls on four sides, which are here. This is in cross section, so it's only two-dimensional. But you've got a box. You pour concrete into that, and if the walls are slightly convergent, as we come towards the surface, it's very hard to pull that concrete block once it's set out of the box because it's locked in. All right? So that's your retention form. The resistance form is the ability of a restoration to resist forces from mastication coming from different directions. Okay, so in order to just illustrate this to you, if we were faced with this lesion clinically and we created a cavity design that eliminated the necrotic caries or dentine, but that we ended up with walls like this, ended up with walls like this, and we placed force here, significant force, which we can generate when we bite our teeth together, here on the restoration, so let's just say this is the restoration. What could happen is the force here could actually cause a tipping out of the restoration, right? So the features of the cavity design which resist that are called resistance form. Okay, so the walls and the floors and their relationship with one another is what gives us both our resistance and our retention form. So slightly convergent, or walls that are at right angles to the floor of the cavity, okay, will give us that retention and resistance form. So when you're cutting into a tooth, that's what you want to create. Okay, let's have a look at another example here where resistance and retention form is less important. This is a large cavity, but it's on the buccal surface of a tooth, which is, or should not be, under direct occlusal pressure, right? So we don't bite down on this part of the tooth. If we do, there's something wrong with teeth aren't in alignment, okay? So our cavity design, removing necrotic dentine, and maybe a little bit of unsupported enamel here, would look something like that. We could place an adhesive restoration in there, and because there's no forces this way or this way, there's none of those, it's not going to tip out. So our design is much more conservative because it's only restricted to just the necrotic tooth tissue. Whereas here we actually do, oops, well that went well, didn't it? Here we actually do have to cut a little bit more of a geometrical shape to allow that resistance and retention form to be achieved. So they're the principles of cavity preparation, which we apply to all cavities, but as you would have seen from those examples, the shape that we end up very much depends on those 3 points in the golden triangle. So that's what you need to think about when you are designing cavities, right? That's the intellectual part of cavity preparation. Just cutting a hole in a tooth, you can train a monkey to do that. Well, maybe you can't, but you know, it's a fairly basic thing to be able to do, just to reproduce a shape mindlessly. But putting everything together and making decisions about what the shape should be, depending on the pathology, the dental materials, and our cavity cleaning techniques, is really the cognitive process that needs to go on in your minds before you pick up the handpiece. Now, let me introduce you to my favourite burr of all time. It's called a pear-shaped burr, and you can see why it's called a pear-shaped burr. Because it's sort of shaped a little bit like a pear, right? Here's the cutting bit. This is the cutting area of the burr. It's this one's covered in diamond grit. So diamond's very hard, it will cut through very hard tissues. You can also get tungsten carbide pear-shaped burrs which have flutes on them. Tungsten carbide is also very hard, as you know, and will cut through hard dental tissues. Now the beauty of this particular burr is its shape. Have a look at the shape here, and then what I want you to imagine is if you went down into a tooth and then pulled the burr across the tooth without lifting it up or down or sideways, and pulled it across, what shape cavity would you produce? Push the pause button and to think about it for a moment. Unpause. You've probably decided now that this is the shape that would result from using the pear-shaped burr in that manner. And, quelle surprise, what have we actually got here? We've got the characteristics of the ideal minimal cavity preparation. So we've got a relatively flat floor. We've got walls that are at right angles to the floor or slightly convergent as you come towards the surface of the tooth. So the cavity design has good retention and resistance form. Your access allows you to eliminate necrotic dentine, and you have convenience form, you're able to get your instruments into place. It also allows you to place an adhesive restoration because the surface area here is relatively small, so your occlusal from the tooth above it is going to have minimal impact on the restoration. This is your ideal for minimal cavities. For much larger cavities, you will of course need to make different decisions about where you place the margins or the outline form and your materials. If it was going to look something like this, okay, you would need to probably have a dental material which was much stronger, much more compressive strength. And if you had a large cavity that needed preparation like this one, this burr may not be the most appropriate one to start with, but for minimal cavities, this is the ideal burr. There's a whole bunch of different shapes of cavity preparation in burrs. We've got round, cone-shaped, tapered burrs, relatively straight burrs, which can all be used to cut different shapes in the tooth. The round burr